Hi, my name is Dave Gloss. I work at Charleston Area Medical Center in Charleston, West Virginia. I've been asked to talk about grading the medical evidence. First, I want to tell you my conflicts. I was a paid evidence-based medicine consultant for the AAN until December of 2017. Well, what does that mean? That means that the Academy of Neurology paid me to help guide through Academy of Neurology guidelines. I was in control of roughly a quarter to a third of the guidelines, ushering through their process. And I also want to reveal an intellectual bias, and that is that I was co-author for some of the guidelines mentioned in this talk. So the format of the talk is pretty simple. I want to talk about some common biases. We'll talk about two different classification systems, the American Academy of Neurology classification system and the Center for Evidence-Based Medicine classification. On the slide, it mentions errors and effect sizes. That was decided to be deleted. We won't talk about that. That will be handled in other talks. So when we talk about biases, the most important grand concept is called validity. Validity is split into two very broad areas. There's what we call external validity, and that's the extent to which the findings of the study are generalizable to other populations. This is a very, very important concept, and many guideline systems don't look at this kind of validity very well. The one that most guideline systems look at very comprehensively is internal validity, and that's the reliability and accuracy of the results of the study. So the main threats to internal validity are two basic kinds. There are biases and confounding. And a bias is any factor which can lead conclusions astray from the truth. And confounding is a factor typically of which you are not aware that influences the outcome by affecting both a dependent and independent variable in an experiment, causing a spurious association. So what are the differences between these two? It's kind of like a bias moves you away from where the truth is, even though you think you might be heading towards the truth. And then a confounder is something that affects both sides of how you're looking at testing a variable. It can affect the population that you're looking at. So, for example, if you were looking at lung cancer and you didn't look at smoking as a risk factor, the results of your study might not be very valid because we know that most people who have lung cancer were smokers, and so you'd be not looking at a variable that would have a very profound impact on your study. Bias, this is the thing which most guideline systems focus in on really well. There are three basic areas of bias. There is bias in trial design, there are biases in trial execution, and then there are after-trial biases. So in trial design biases, there's a bunch of biases. The most common ones that people talk about are biases in outcomes, examples of convenience, control group biases, problems of allocation concealment, problems in blinding, spectrum bias, and problems of primary outcomes. So what I want to do is just go over each one of these one at a time. So the choice of outcome is really important. Outcomes ideally should be objective, or if not able to be objective, they need to be read by someone who's blinded to the treatment they received. So what's an example of an objective outcome in epilepsy? Death is an objective outcome. It doesn't really matter who's looking at that outcome. We know that the outcome's not going to be altered by whoever looked at it. Seizures are, unfortunately, not objective. If patient has a funny feeling, that some physicians may say that that's a seizure, some may not. Patients who have auras, this can often be confusing, even amongst specialists, whether that represents a seizure or not. And so outcomes like seizures need to be judged by somebody who's blinded to the intervention that the patient received, so that they're not unduly influenced by that knowledge. And an outcome determined by a treating provider who knows which group the patient is in is considered no better than a case report per AAN standards. So that means that if the person who designed the study is the treating provider, which most commonly is the case, you can't use that data in any way that's meaningful. The next big area of bias is in sampling. So sampling is basically choosing a sample of elements of a total population of elements. There are two big kinds of sampling. There's probability sampling and there's non-probability sampling. Probability sample is pretty much very simple. Every element of the population has a known probability of being included in the sample, and that's the preferred kind. And non-probability sampling is where it's not known the probability of an element being included in the sample. So the most common case where we see this is convenience sampling. And this is just where we pick people that it's easy to reach. For example, interviewing shoppers at a shopping mall, interviewing patients in your clinic. And that's one of the most common methods for non-probability sampling. Unfortunately, when we do sampling like this, you can't really do things that are meaningful statistically. You're unable to compute a confidence interval, and you can't really compute a region of acceptance of a hypothesis test, which means that you can't do any hypothesis testing. Control group biases are very important. We frequently see these when we are downgrading studies. And so an ideal control group has identical characteristics as the experimental group. This is typically shown in Table 1 of most papers, where you have your control group on one side and your experimental group on the other side, and you show that all the important covariates are equal. Now, if you're testing lots and lots of covariates just by 95% confidence, some of them may end up being statistically significant. And the reason why we look to be sure that the experimental and control group are identical is that this allows one to give some treatment to the experimental group and know that as changes occur, it's due to the experiment that you did. The presence of a control group is so important that those trials which do not have a control group are considered to be at the same bias as the case report. This has massive impacts on much of the older medical literature. Much of the older medical literature were cohort studies where they received some sort of treatment. And unfortunately, we found that the bias is just too high to consider those studies helpful in making medical decisions. Okay, the next one of bias that I want to talk about is selection bias. And it basically occurs when criteria used to recruit and enroll patients into cohorts are inherently different. So an example would be, let's say you're looking at two groups of patients. One group is sick and needs some treatment, and another group is normal. And that's the group that's normal is the control group. Well, those groups are inherently different, and you wouldn't expect that how they would evolve in time would be the same. Another place where we see very frequently selection bias is in retrospective studies or case control studies. These occur when the exposure and the outcome have already occurred at the time of study inclusion. And this is part of the reason why, ideally, you would like to do a prospective study where the outcome is unknown at the time of enrollment into the study. The next bias we want to talk about is called channeling bias, and that's where patients are channeled into groups depending on the patient prognostic factors. The most important example of this is what we call allocation concealment, which occurs very frequently. So allocation concealment is that the person randomizing the patient to be enrolled does not know what the next treatment allocation will be. So there was a very lovely meta-analysis done about this, looking at the overestimation of treatment effects. So we all know that blinding is one of the most important things that we can do to eliminate bias in trials. The point estimate for the effect of blinding is 0.86. So that means that, roughly speaking, the outcome is overestimated by about 15%. When you look at a whole bunch of studies that don't have blinding. The way that you do this estimate is that you look at cohorts which aren't blinded and you compare them to cohorts that were blinded, and you see the differences in the outcome. You can do the same sort of thing looking at allocation concealment and find that the overestimation is 0.7, or in their language, about 30% overestimation of the outcome. This suggests that the effect of allocation concealment on the outcome may actually be greater than blinding, which is very counterintuitive. But the point estimate for the estimation of the effect of that is almost double. So some examples of acceptable allocation concealment is when a pharmacist or someone unrelated to trial does the allocation because they wouldn't be able to be biased in choosing what patients would be channeled into which group. Sealed opaque numbered envelopes is acceptable, although there are known examples where that was circumvented by researchers. One of the things that helps a lot is random block size randomization. So basically, you put patients in blocks and randomize them in individual blocks. And then if the researcher doesn't know the block size, and he can if it's random, then he's not able to guess what the last person in the block is going to be assigned to. If you have a certain number of blocks, sometimes researchers can figure out what the last person is going to be assigned to and can unconsciously push a patient or channel a patient into a specific group. Okay, blinding, this is the famous one that everybody knows about. It prevents a lot of bias because somebody who's blind cannot advertently or inadvertently alter the outcome. And ideally, it's what we call triple blinding. The researcher is blind, the patient is blind, the outcome assessor is blind. Unfortunately, this is often not possible. Objective outcome assessment can be a way around not having triple blinding, but that's also difficult to achieve. Spectrum bias is something that we see commonly in diagnostic studies. And here, patients to be included should include a wide spectrum of patients, some with mild disease, some with moderate disease, some with severe disease. If you have a study where all the patients have just severe disease, you're looking at the most extreme expressions of the disease, and the diagnostic testing that you're doing may not apply at all to the more typical patients who have the disease. This is very frequently done, and it typically exaggerates the diagnostic accuracy of a test. I guess if you create a test that says you're only looking at the severe examples of the disease, then it wouldn't be prone to the spectrum bias. But most typically, these tests look at the severe examples of the disease and then suggested that their test was good at diagnosing disease X, which has a problem with generalizability. The next one is another problem of diagnostic testing. It's called incorporation bias. This is frequently seen in older studies, and that's used the test result as part of the definition of the disease, and this makes a diagnostic test no better than a case report. Okay, moving on to threats to trial execution. There are lots of different kinds of biases here. I just want to go over probably the three most common or important kinds of bias: interviewer bias, recall bias, and transfer bias. So interviewer bias is a systemic difference in how information is collected. This is a known problem when disease status is known prior to enrollment. It sort of highlights the importance of blinding, like what might commonly happen with an interviewer who knows that a patient has a disease. They might ask things that they wouldn't ask people in the control group, and then you end up with different answers. The next big bias is recall bias, and this is where a patient unconsciously colors their perceptions of prior events based on the effect of treatment. So like if the treatment is successful, they may think it was successful earlier, or they may not remember that things didn't go as well if they know that they were treated. This is part of the importance of blinding patients too. And then the last major kind of bias is called transfer bias. This is one where patients lost to follow-up different than the patients retained in the study. And are patients who stop following up likely to have better or worse outcome than those who continue to have follow-up? Like if the treatment was successful for some patients, maybe those patients decide they no longer need to be involved in the study because they're better. Or if a treatment is not doing anything for patients, maybe they lose hope and then they stop being part of a study. And again, this is where blinding is super important, because if a patient doesn't know if they're being treated or not, then the patients who are lost to follow-up are unlikely to be significantly different. Lastly, the sort of third big umbrella about bias is threats to publication, and this is basically publication bias. It's well known that negative trials are harder to publish than positive ones. And one of the key factors is that trial sponsors may be unwilling to let them to be published when they're negative, so that their drug or treatment or whatever is not seen as favorable. This is part of the reason that there was a consensus statement that all randomized controlled trials must be pre-registered, and then and all prospective trials not deemed purely observational must be pre-registered prior to patient enrollment. And you can't really get into any of the major medical journals without this happening. This makes it so that if there's a negative study that's being blocked by either loss of interest from the researchers or by trial sponsors, it's a little bit more obvious that that's occurring. Okay. Now I want to talk about two grading systems. I'm going to talk about the AN grading system and the Sevener for evidence-based medicine grading system. We're just going to highlight some of the information about these grading systems, to go through these systems in real detail and allow the listeners to the talks to be able to grade papers would require a lot more explanation and time. I'm going to try and go through as much as I can in the time that I was allotted to talk about these things. I chose the American Academy of Neurology and the Center for Evidence-Based Medicine grading systems because these are the two most important grading systems for epilepsy physicians. The AN risk of bias system is a four-tiered system. Class 1 has low risk of bias, and it's pretty hard to become Class 1. Class 2 has moderate risk of bias. Class 3 is moderately high risk of bias. And Class 4 is high risk of bias. These are things like case reports or studies that don't have certain basic characteristics. So in the AN system, there are 6 different filters from which we grade studies. And the filters are really quite different. The filters are therapeutic studies, cost-effectiveness studies, that's the one I wrote, causation studies, prognostic studies, diagnostic accuracy studies, and population screening studies. So basically, if you're writing questions for a study, it can be really helpful if you determine what kind of study it is and then look at the criteria that you're being graded on. And this can help you choose elements which you're using or including in your study design, which can make them more impactful later on because they'll be considered to be at lower risk of bias. Due to the time allotted to me, I'm only able to go through a single one of the criteria. This is probably, we're going to go through the therapeutic criteria. This is the most important one and the one that's most frequently used. Okay, so to reach a Class 1 level or low risk of bias, you have to have a randomized, controlled trial in a representative population. There has to be triple masking, as mentioned before, in blinding. There needs to be blinding of the researcher, blinding of the patient, and blinding of the outcome assessor. The baseline characteristics of the control group and the experimental group must be equivalent. Or if they're not equivalent, there needs to be appropriate statistical adjustment for that difference. And then there are certain characteristics that must be included. There has to be concealed allocation. You cannot have more than 2 primary outcomes specified. You have to have inclusion and exclusion criteria specified. And then 80% of those enrolled into the trial had to have the outcome measured. So this is important criterion because for some trials, some areas may have more than 80% measured, and in other outcomes, less than 80% was measured. So something that we see infrequently, but that we do see, is that trials may have multiple different grades or classes based on the outcome. There are special criteria for non-inferiority trials. Dr. French was instrumental in getting these criteria included. These standards, again, for a Class 1 trial is that non-inferiority trials must have the authors explicitly state a clinically meaningful difference to be excluded, by defining a threshold for equivalence or non-inferiority. The standard treatment is substantially similar to that used in previous studies establishing efficacy. Inclusion and exclusion criteria for participant selection and the outcomes of participants on the standard treatments are comparable to previous studies establishing the efficacy of the standard treatment. Interpretation of the study results is based on per-protocol analysis that accounts for dropouts and crossovers. And then crossover trials, this is part of what I included. Both period and carryover effects are examined and statistical adjustments are performed. And baseline characteristics are statistically equivalent, just like typical trials. So a group that receives the first treatment and then the second treatment is the exact same, has the exact same characteristics as the group that receives the second treatment than the first treatment. Class 2, this is where a randomized controlled trial lacks one or two of the criteria A to E. So these criteria: concealed allocation, no more than 2 primary outcomes, inclusion, exclusion criteria specified, and 80% had the outcome measured. And E is about the non-inferiority trial. And then these propensity scoring, which is a way to look at groups. They're given us sort of their baseline characteristics and confounders. Is sort of numerically crunched into a number, which allows people to be matched. This is a way of matching. And it has to meet the criteria B to E. And it's required to have masked or objective outcome assessment. And the baseline characteristics must be presented and have to be substantially equivalent. So that's a little bit softer than the criteria for Class 1. Non-inferiority trials are allowed to be missing only characteristics 4. So if we go back to that, that's the interpretation of the study is based on per-protocol analysis. Everything else, 1 to 3, has to be included in order to be Class 2 non-inferiority trials. And then crossover trials, there are 2 basic characteristics. There was the A to B is equivalent to B to A in terms of the criteria looked at, and period and carryover effects are examined. So you can skip 1 and still be Class 2. Class 3 trials are all controlled trials, which include studies with external controls, for example, historical controls. So this is a really easy way to create a study in your own clinic. Here you look at your patients before you did something. Doesn't really matter what it is. Those are your historical controls. And then you just take the patients in your clinic after you did something. That's a very easy way to sort of create a Class 3 study in your own clinic. There has to be a description of major confounding differences between groups that could affect the outcome, and the outcome performed by someone who is not a member of the treatment team. So one of the frequent things that we use in epilepsy is seizure diaries. And an example of that would be the VNS update, which explicitly allowed seizure diaries for epilepsy trials to get Class 3. And then non-inferiority trials, which do not have any of 1, 2, or 3. If they're missing just 1, they're Class 3. And then crossover trials, which don't have either of the expected or wanted characteristics. And Class 4 is basically trials not meeting Class 1 to 3. And if you have no control, you're Class 4 by definition. It doesn't matter how large the group is or how well you handled it. It's automatically Class 4. One of the things that's really important to understand about the Academy of Neurology methodology is that it's constantly evolving. As I had mentioned earlier in my lecture, there were little pieces that I sort of included. There's a piece that Dr. French was instrumental in getting to be included. And this is part of the evolution that's occurring. And in particular, we've had three major changes in our process manual since 2004. And so here's a cool way of looking at these changes. And this is from the Duchenne's guideline from 2005 and the update on the Duchenne's guideline. So there were 25 articles included in the original Duchenne's guideline by Moxley, and the rating of those, or the risk of bias of those trials are included in blue. And I used the 2014 manual when I did the update of it, and we rated the trials all over again using the updated methodology. And as you can see, not a single one of the Class 1 trials remained Class 1. And of all the Class 1 and 2 trials, only 2 remained Class 2. Everything else became Class 3 and Class 4. And one of the things to note is that most of the Class 1 trials ended up as Class 3, and a lot of them ended up as Class 4. Okay. AM methodology is used to classify some papers submitted to the Neurology Journal. And I've been told by some granting agencies that they use the AN methodology to help determine funding priorities. What's nice about the AN methodology is that the rules are pretty clear-cut. When authors are notified that their papers are going to be judged using the classification system and choose to submit what they think the ratings should be, they're often off by one, usually one higher than the rating ends up being, but they're in the right ballpark. And I strongly suggest when making a proposal for research, you consider looking at the grading system and make sure that you have everything included to have the highest class possible. And this may help you get your funding. We're going to talk about the Center for Evidence-Based Medicine grading. They have 5 different areas. They have therapy, prevention, etiology, harm, which is their most common one. They have prognosis, diagnosis. They have a little bit different than the Academy of Neurology. They have an area for differential diagnosis. And then somewhat different than the Academy of Neurology. The Academy of Neurology has a cost-effectiveness area. They have an economic and decision analysis, which is similar but not identical. So again, we're going to look at therapy just so we can see how they're the same or different from the American Academy of Neurology, and also it's the most commonly used filter for the Center for Evidence-Based Medicine. Okay, Class 1A is basically a systematic review of homogeneous randomized controlled trials, and then here they have a specific language that they use to talk about homogeneity. In this case, basically, they're referring basically when there's worrisome heterogeneity, and then if there's worrisome heterogeneity, the level is tagged with basically a negative sign. So 1A minus would be a systematic review of heterogeneous randomized controlled trials. And then for measurement of heterogeneity, there are several different measures. Probably the most commonly used one is what's called I-squared. The sort of rule of thumb is that there's small heterogeneity with 25%, moderate heterogeneity with 50%, and high heterogeneity with 75%. Rarely, I-squared can be 0. And sort of very broad strokes, if you're less than 50% with I-squared, you're good. If you're greater than or equal to 75%, you're not good. And some people like to use the 50% cutoff. So people argue about between the 50 to 75% cutoff. And there are some statisticians which don't like the measure at all. But still, it's the most commonly used in meta-analyses and can be helpful determining whether you have homogeneous or heterogeneous outcomes. Okay, and then they further split their class 1 into 1B and C. 1B is an individual randomized controlled trial with narrow confidence intervals. And 1C are the so-called all or none studies. These are ones where all patients died before treatment was available, but now some survive with a treatment, or when some patients died previously before a treatment and now nobody dies after a treatment. And then here, these studies get downgraded with a negative if they have wide confidence intervals. For their class 2, they have, again, 2ABC. Sorry, there's a typo in there. 2A is a systematic review of cohort studies without troubling heterogeneity. 2B is an individual cohort study, including a low-quality RCT, such as those that might have less than 80% follow-up. So this is actually very similar to the Academy of Neurology. And 2C is the so-called outcomes research studies, which look at outcomes of a public health intervention. Class 3 is split up into 3A and 3B. This is 3A is systematic reviews of case control studies without worrisome heterogeneity, and 3B are individual case control studies. Now we're going to look at Class 4 for the Center for Evidence-Based Medicine. For them, Class 4 is case series and poor quality cohort and case control studies. For them, they have a specific definition of poor quality cohort studies. These are ones which fail to define comparison groups, fail to measure exposures and outcomes in both groups, i.e. ones that weren't blinded. These are ones which fail to identify or control for confounders. Note this is one of the differences between the AAN system and the Center for Evidence-Based Medicine system for the Academy of Neurology. The failure to look for confounders leads to a different class than looking for confounders and finding that they're different. And then for them, poor quality cohort study includes failure to carry out a sufficiently long and complete follow-up of patients. Then for poor quality and case control studies, this is failure to clearly define comparison groups, failure to measure exposures and outcomes in the same objective way in both cases and controls, and failure to identify or appropriately control known confounders. Lastly, our Class 5 studies. We don't have Class 5 studies in the Academy of Neurology, but the Center for Evidence-Based Medicine has Class 5 studies are those with expert opinion without critical appraisal, those based on physiology, those based on bench research. So if we go back and sort of compare the Academy of Neurology methodology with the Center for Evidence-Based Medicine methodology, we can see some very important differences. So for them, a low-quality randomized controlled trial is a 2B. For the Academy of Neurology, a randomized controlled study can be Class 1, Class 2, or Class 3. And it's actually pretty frequent for randomized controlled studies, particularly ones from the older medical literature, to end up as Class 3. It's rare Class 1 studies that, it's rare randomized controlled studies that end up as Class 1, and ones that only have a single defect end up as Class 2. This is the end of the lecture. I hope you learned something by listening, and thank you for giving me this opportunity to talk.